Hi everyone, it's Laura. Just a update on bone resorptive therapy, or as we know it, Zometa and Denosumab. All right. So I just want to go over what is bone resorption, why it's important, some physiological and pathological aspects, what's the therapy we use, and take home. So our bone cells, the biggest bone cells that we have, or sorry, the most important, the primary cell responsible for bone resorption or bone breakdown is osteoclast. They actually take away old damaged bone, and that allows for new bone formation. They are actually regulated or influenced by other cells in the bone microenvironment, such as the osteoblasts and osteocytes. And osteocytes are the master regulators of bone. They sense mechanical stress and they send signals to osteoclasts and osteoblasts to do their job. Osteoclasts also have continuous role in bone remodeling just to help maintain that skeletal health and repair. And then we have the osteoblasts, and they're the builders. So they deposit new bone matrix called osteogenesis. They mineralize the bone so it makes it harder and stronger. They talk to other cells like osteoclasts and osteocytes to regulate bone remodeling. And they also secrete osteocalcin, which is used to regulate fat and energy metabolism, but it also influences osteoclast activity. And how does normal bone physiology look? So, bones are living tissue, constantly growing and changing, even although we cannot see this. And this is just a pictorial diagram to represent this. So, the osteocytes, those master cells within the bone matrix, detect the damage. They send signals, triggering the osteoclast to become activated. So, they then remove and break down small amounts of bone called resorption, and then that is balanced by deposits of new bone or new mineral to maintain bone strength by the osteoblasts. And then when they are finished, they either die or they become osteocytes, so the cycle starts to repeat itself again. It's a coupled process, meaning that it kind of happens at the same area of bone. And when it's complete, they go into quiescence, which is a resting phase before the next cycle starts again above, as shown in the diagram. It's a coordinated process that happens because we don't want more resorption than formation, or we would have problems with the bones. So how is this maintained? So our homeostasis or regulation can happen via hormonal control. So we've got parathyroid hormone in the body, major regulator of calcium. It can stimulate bone resorption directly and indirectly. So directly, PTH or parathyroid hormone activates osteoclasts, and then indirectly it can stimulate release of local factors, right, like rank L, which we'll talk about, and that further promotes bone resorption. So we also have vitamin D, or its active form is calcitrol, and that enhances calcium absorption in the intestines, and it stimulates bone formation. And we've got calcitonin as well. That's produced by the thyroid gland and directly inhibits osteoclast activity. We have estrogen, and that plays a role in preventing excessive bone resorption, particularly in females. It inhibits their activity and promotes osteoblast function. And then obviously as ladies become menopausal, they don't have as much estrogen, so we can have problems with increased resorption, which puts females at that higher risk of osteoporosis. We also have other thyroid hormones that are produced, and they help with metabolism, which helps to balance homeostasis. There are sex steroids such as androgens, like testosterone in our gents, and a bit in the females as well, crucial for bone growth and development, impacting on bone size and strength. We also have cytokines and growth factors. So cytokines like interleukin 1 or tumor necrosing factor 8 alpha, and some growth factors that help release from the bone cells to influence bone resorption. And then when we look at stress on the bones, so we have a degree of physical force called mechanical stress, that influences bone remodeling. And And then we also know that if we have an appropriate level of stress, like repetitive mechanical stress, such as weight bearing exercises, that can promote healthy bones and formation and inhibit the resorption. So we have good, healthy bones, strength and density. But if we have excessive stress or prolonged mechanical stress, like high impact activities, or even prolonged bed rest, that can increase bone resorption and potentially weaken the structure. And that kind of goes into the disuse as well. So, like if someone's immobilized for a long time or during a hospital stay, or they have a lack of mechanical stress, or even space flight as well, that can reduce bone density and lead to increased resorption and decreased formation. So, that weaker bone. So, just touch on physiological and pathological resorption. So, physiological resorption is dynamic. So old bone is resorbed, new bone is formed. It's a crucial process to maintain strength, adaptation to mechanical stress, and regulate calcium levels. It's age related. Resorption becomes more prominent as we age. So that's why we get age related bone loss as we get older. It's a natural process. It happens to maintain healthy bone so that the old bone's broken down and replaced, and it's maintaining that homeostasis. If it becomes abnormal process in any way, or it occurs excessively or inappropriately, then it becomes pathological and it can lead to bone loss, fractures, other bone complications. People can develop osteoporosis, infections, or tumours as well. And that's not how people get cancer in the bone, but it can happen as another effect. Pathological bone resorption can be disease related, so we have that loss of bone density, increasing susceptibility to fractures, so they can be osteoporotic. They can have that lower than normal bone density, not as severe as osteoporosis, but they can be osteopenic, where just got that beginning of a change within the bone matrix. Rheumatoid arthritis as an autoimmune disease causing inflammation and destruction of bone and cartilage. And also gums can get affected. So we can get a periodontitis, which is a gum disease because of loss of bone around the teeth. Also, there's injury related pathological changes because of trauma, so MVAs, MBAs, fractures that can happen that can trigger localized bone resorption. As mentioned, tumours. So there can be primary bone tumours, and there can also be metastatic tumours within the bone, and they can also induce bone resorption. And as mentioned earlier, immobilization, so that lack of mechanical stress on the bone. And a lot of patients will have at some point in their lifetime some bone density testing. So whether they have a bone mineral density scan or a DEXA scan or a DXA, most commonly used is a DEXA scan. It's what is it again? Sorry, it is a dual energy X-ray. Sorry. That is non-invasive and quick, and it scans to measure the bone density. It's reported as a T-score, which can be -1 is considered normal, -1 to -2.5 is osteopenic, and -2.5 or lower suggests osteoporosis. There can also be a Z score actually documented within the patient scan, and these all compare the patient's bone density to the average bone density of people of the same age and sex. So it's just comparing that to see what it would be if it was a healthy young adult of the same sex. Bone biopsy, very less common unless it's absolutely necessary because of the invasiveness of it. But if the non-invasive methods are inconclusive, then we have to get a reasoning behind the bone loss to guide treatment. Normally women over the age of 50 because they're coming to the menopausal state, or males over 65, younger women who've gone through menopause with risk factors for osteoporosis such as our patients, fractures from a minor bump or fall in anyone over the age of 50. And there's other risk factors as well, such as family history of a fragility fracture, unhealthy levels of smoking or alcohol, vitamin D or calcium deficiency, low body weight, recurrent falls, immobilization, long-term corticosteroid therapy, and some other conditions that put people at increased risk, such as early menopause, endocrine hormone disorders, anorexia, nervosa, diabetes, and HIV. Bone density testing is considered really safe. It's very low levels of radiation, but as we know, should be avoided in pregnancy. So treatment and medications, and as I said earlier, just at the beginning, I'll just focus on Zometa and Denosumab just because for the sake of time. So bisphosphonates, Zometa, zoledronic acid, or that's the intravenous one, or you can have IV pamidronate, or there is oral such as alendronate, risedronate, and clodronate. Haven't seen that one actually, to be honest, but it's out there on the drug list. So bisphosphonates actually are absorbed by the bone mineral at sites of active bone resorption. They are then ingested by the osteoclasts that break down the bone, and inside the osteoclast, they disrupt the critical pathways of their regeneration, which leads to programmed cell death or apoptosis. So it effectively reduces the bone turnover, increases the density, and the diagram just shows that as a pictorial. So the uses for it, we've got indication in early breast cancer. So we know that using it in early breast cancer, there was a meta-analysis showing that Zometa can offer a survival benefit in certain patient populations, and the benefit was seen mostly in the postmenopausal ladies. So it was considered that Zometa had significant benefits in the postmenopausal patient cohort to significantly reduce distant recurrence, especially in the bone, and decrease breast cancer mortality. Premenopausal women, the use of Zometa was less clear, but then the general consensus was that it was stronger evidence for postmenopausal. The mechanism of Zometa, with its ability to inhibit bone resorption, showed a direct impact on the spread of cancer to the bone. So it reduced the risk of bone metastases, reduced the fracture risk as well, in addition to its anti-cancer effect. And also there was a little bit of controversy over whether it should be 2 to 5 years, but Zometa in the early breast cancer population is 6 monthly for 3 years. So we have a role in our population, metastatic breast and metastatic prostate, who have got metastases to the bone from their primary breast or prostate cancer. So we know that Zometa giving to these patients actually helps reduce the skeletal related events. So by inhibiting the osteoclasts, they're strengthening the bone and making them less susceptible to damage from cancer cells. We know from the studies that there is improved pain management, and within the prostate population, a lot of their bony metastases are osteoblastic, so it's that overgrowth of bone that happens, and we know from the studies as well that Zometa still works on these osteoblastic lesions to help our prostate gentlemen. It also has a positive impact on improving overall survival in both populations. And again, dosing frequency actually depends on the disease and the patient, how long they've been on it, etc. So Zometa, it comes as a 4 or 5 milligrams. It's normally intravenous, and it's a nitrogen containing bisphosphonate that disrupts osteoclast activity and inhibits bone resorption. So on the right hand side, I've got the PBS indications for each dose, so you know. It can be given yearly for osteoporosis or monthly for metastatic breast or prostate, or a little bit less frequently if the patient's been on it for a while, they've got stable disease, and that is physician dependent and patient dependent and their disease. So it's completely absorbed by the end of the infusion, which is roughly 15 minutes. It binds, it's got moderate plasma binding, and it's actually got a triphasic elimination. So it drops down to half of its dose that's administered within 2 hours, and then it's got a slow excretion time or elimination, how it's excreted from the body, up to 167 hours. So it's actually passed out via the kidneys completely unchanged. So it does have renal clearance, as mentioned, so it is dose modified for any renal dysfunction, but it's used as well for, if anyone doesn't know, that symptomatic Paget's disease of the bone. So that is physical symptoms reported by the patient that are caused by the disease, which is actually a rapid disorganized breakdown and regrowth of bone. And the advantages really is it bypasses the GI tract, so you can ensure compliance within the patient. Busy slide, sorry, but it's a lot of side effects that can happen. On the left is the common, such as that flu-like symptom. They get those arthralgias, myalgias, aches and pains. We do know there's a renal dysfunction and the risk of hypocalcemia, but the others, it's just really patient dependent. But looking at the cardiovascular on the rare side, we're really worried about palpitations, chest pain. Respiratory would be cough, difficulty breathing, wheezing. Gastrointestinal, if they get diarrhea, constipation. Central nervous system, we worry about diarrhea, constipation, difficulty sleeping, dizziness, pins and needles, eye problems, muscle cramps, feeling that they've got blood vision. Integumentary, they can get a rash, itchy skin, hives, and just allergic reaction can happen with any drug, as we know, and to ensure that they have pathology prior, just to make sure that their electrolytes are stable and their calcium, just before we give the infusion, to make sure that we don't cause them any more problems. And they can sometimes get a localized irritation at the injection site. So denosumab. So denosumab is a fully humanized IgG2 monoclonal antibody that targets bone loss. It's a more potent anti-resorptive agent, and it's given subcutaneously. So denosumab blocks is a protein called rank L that's on the osteoclast, and it's essential for formation, function, and survival of them. So the rank L binds to rank receptor on the osteoclast, and that actually helps it grow and survive. But when denosumab binds to rank L, it stops rank from being activated. So that prevents osteoclasts from maturing, it reduces their activity, and it leads to the breakdown of the osteoclasts. So again, denosumab, other names Xgeva, Prolia. Sometimes the Prolia is 60 milligrams and the Xgeva is 120. Now, Xgeva is normally a 4-weekly subcutaneous injection, Prolia is 6-monthly. If it's been given for giant cell, as the indications are on the right side on the slide, they can have an extra dose 1 to 2 weeks after the initial dose. Its absorption is non-linear, so it looks at the saturation of the drug on the receptors before it actually starts to eliminate it from the body, depending on how much has actually been absorbed. It's eliminated via the reticuloendothelial system, so that's actually more commonly known as the mononuclear phagocyte system. So the network of cells, including the macrophages that remove the foreign particles and dead cells from the body and debris, using phagocytosis. So its maximum effect is around 10 days. Its concentration can decline over 4 to 5 months. Its half-life is about 32 days. So what that means is, after the injection's been given, when does it get to half the dose? It's just over a month. So it's got a longer duration of action as well. So some side effects again, denosumab. So left is the common, right is the rare. On the rare, there is osteonecrosis of the jaw. It does happen, and we have to make sure that the patients have a dental check beforehand, because it is quite significant, and I'll talk about that in a little bit more detail. But basically, they can get the musculoskeletal pain, they are at risk of hypocalcemia, they can have some allergic reactions. and they do have risk of infection as well. If you have a patient who's on denosumab and they come in and they're saying they've got severe back pain or pain in the thigh bone, have to be worried about atypical femoral fractures. So they can happen as well when someone's been on bisphosphonates for a while. We can actually see bisphosphonates and Rankel that patients are at risk of that bone change that happens after a while, and we are at risk of them having these atypical fractures. So just a little bit more about osteonecrosis of the jaw, because if it happens, it's actually quite serious. So it's exposed bone, exposed bone. They can get gum pain, they can have non-healing wounds and swelling, and that's normally after they have a dental procedure. But the most common sign is exposed jawbone, and that's pretty serious. So all patients should have a dental workup pre commencing denosumab or a bisphosphonate, and they also should have regular dental reviews throughout the treatment with the denosumab or the Zometa. Treatment depends on the stage of the condition. So if it's early and we've caught it early, then it's just very good mouth hygiene, pain relievers if they get pain, antibiotics if needed, and antiseptic mouthwash. If it's more serious, then we can refer them for surgery to or the dentist or the orthodontist to debride anything that needs to come away, and then let the gums heal over the bone with antibiotics and pain relief. If it's more serious, then it is surgery to they have to take away the part of the jawbone that's died from this. So it's really important that if someone's on these treatments that we're actually looking inside their oral cavity, that they are having regular dental reviews, and that they report any jaw pain or dental issues to us as soon as possible. Now, patients still can have dental procedures done, like fillings and cleaning, but if they have to have a tooth removed, then it's a little bit more serious, and we need to know in advance because they have to have a drug holiday. And this is just what it kind of looks like. So bottom left and bottom right pictures are what the exposed bone looks like, and then the x-ray above is to show you the change in the density of the teeth within the mouth. So just quickly, bit of take home. So the drugs, the bisphosphonates, Zometa, and then denosumab, potent inhibitors of bone resorption. The administration methods vary, so we know that the Zometa's IV, denosumab is subcut. So we have to really assess the patients to make sure they've got correct access. Are they suitable for IV, or is subcutaneous better? Depends on appointments, how often are they at hospital, can they get transport, everything else. So it's actually patient selection is quite careful. We don't normally use oral within the cancer population. While they're really quite safe to be given and actually help with bone health, because we know that these patients are at risk of fractures secondary to weakened bones, and especially in our postmenopausal women and our older adults, when we are treating a lot more older adults. We've got to be careful because we have to make sure the patient is extremely well educated on what to look out for. So they do need that pre-treatment assessment. We need to know if their renal function is appropriate for treatment. Zometa has to be dose modified. Denosumab doesn't. We need to know that their calcium is stable. Are they on calcium and vitamin D? And what is their baseline renal function? Have they had a dental examination? Do they need any work done before we start? Do we need to postpone it? Can we start it right away? Then do they need, again, dose modification? Make sure that they've got regular follow-up with us or GP, or are they under anyone else like ENT if they've had issues or an osteonecrosis of the jaw previously. Again, talking about drug holidays. So if they're having invasive dental work, then we need to reduce that risk of actually causing death to the jawbone. And drug holidays as well if they've been on it for a while and we're worried about the risk of an atypical fracture. Really good education on when to call, who to call, and side effects to look out for, and just making sure that they're well hydrated to maintain their kidney function throughout treatment. So If anybody's got any questions, then feel free to send me an email. Happy to answer anything, happy to get feedback, happy to look at any other presentations going forward in the future. All right, everybody, thanks for listening. See ya. Bye.